Good morning. Today's presentation is our Unit 2 case studies with video presentation. My name is Katrina Alexander, 81520 for Medical Biochemistry 1005. And I apologize, we had storms this last week through western Iowa and northern Illinois with straight line winds at 90 miles an hour. So we just got electricity on after 5 days, or I would be a little bit more prepared or refreshed for my presentation today. I chose case study 3 and case study 4. My first case study, this patient presents with decreased blood insulin serum levels at baseline at 1 hour post glucose load, indicating the possibility of insulin-dependent diabetes mellitus or type 1, also called juvenile onset diabetes. The clinical presentation, as well as the mother's medical history and laboratory results, support this finding as the clinical picture for type 1 diabetes. A definition of type 1 diabetes correlates with impaired synthesis and secretion of insulin. This type of diabetes is often associated with autoimmune destruction of the beta cells of the pancreas, and therefore any functions of the pancreas are also impaired or impacted. Due to the decreased function of the beta cells, glucagon secretion is also impaired and will not be suppressed. When glucagon is not suppressed, this also contributes more to the state of hyperglycemia. And hyperglycemia also occurs due to reduced glucose uptake by the tissues. One of the primary reasons that hyperglycememia occurs in this case. Also, there's impairment of glucose transporters and an increased production of glucose secondary to gluconeogenesis and glycogenolysis. In this case, impairment in carbohydrate, lipid, amino acid metabolism, and the symptoms that are presented in most cases with type 1 diabetes, if left untreated or uncontrolled. Ketoacidosis occurs due to increased mobilization of fatty acids and increased conversion of fatty acids with increased cholesterol synthesis as well. Glycosuria occurs due to the kidney's inability to absorb the excess glucose from the urine, resulting in glucose spilling over into the urine. And due to the osmotic effect of glucose as well, increased urine output occurs. Due to the decreased volume imbalance from glycosuria, polydipsia will occur, presenting with increased thirst. More output, you want more urine output, you have to balance it. Your body is signaling for you need more water intake. The patient's fasting blood glucose levels would be increased above normal range. If when asked what would the blood glucose levels look like, of course they would be above normal range. Without secretion of insulin, the enzymes need to initiate glycolysis and are impacted. Insulin plays a role in decreasing the effect of glucocorticoids normally, and glucagon stimulated CAMP. Without this antagonistic effect, synthesis of gluconeogenesis is continued with increasing blood glucose levels. The 3 regulatory enzymes in glycolysis are glucokinase or hexokinase, phosphofructokinase or PFK1, and pyruvate kinase will be decreased due to decreased insulin levels as well. And my references are listed below following my case study. The next case study is case 4. And in this case, the infant should be evaluated for glycogen storage disease due to the inability to maintain blood glucose homeostasis with continued hypoglycemia following the administration of epinephrine. This is also called a glucagon or epinephrine challenge test, in which I'll talk about that later, which I found in a journal article, which is interesting due to this being a rare disease that they, I don't know if this is something they regularly look for or screen for with after the presentation. Excuse me, let me pick up. The infant demonstrates symptoms of hypoglycemia before subsequent feedings and unable to utilize stored glucose and glycogen to maintain normal blood glucose levels. Epinephrine, of course, stimulates glycogenolysis in the liver and muscle due to the stimulation of phosphorylase secondary to the generation of CAMP and the enzyme adenyl cyclase. CAMP binds to the phosphorylase kinase and converts it to its active form. In turn, phosphorylase B is converted to phosphorylase A, and this converts it to its active form. Phosphorylase B is converted to phosphorylase A and catalyzed in the breakdown of glycogen. The process of glycogenolysis produces energy, of course, in the form of ATP, NADH, and lactate production. The physical exam revealed hepatomegaly, an enlarged liver, a common exam finding in this type of disease, a glycogen storage disease, due to the accumulation of glycogen and fat in the liver and kidney, resulting in imaging. It would look enlarged. A glucagon or epinephrine challenge test was administered with epinephrine. It can also be administered with glucagon. In this case, it was epinephrine. Resulted in no increase in blood glucose concentration and increased serum lactate levels, which was consistent with the findings from our case study. And this was consistent with glycogen storage disease as well. Infants that remain untreated will also demonstrate symptoms such as lactic acidosis, hyperuricemia, hyperlipidemia, hypoglycemic seizures, growth retardation, osteoporosis, delayed puberty, gout, renal disease may also be indicated in long-term effects. There are several subtypes of this disease. The initial subtypes, I believe, are glycogen storage disease type 1 and type 2, but they also have common names, I guess, or I wouldn't say common names. The subtypes are broken down with varying names. They include von Gert disease, also known as glycogen storage disease type 1A. Okay, so that's how their classification is broken down. Pompe disease, or POP disease, known as type 2, Corey disease, known as type 3, and McArdle disease, known as type 5. Throughout the patient's life, they must maintain a low sucrose, low fructose diet, maintain adequate nutrition, and monitor for hepatic adenomas. In this case, hereditary fructose intolerant would not be supported since he or she had only ingested breast milk, and breast milk is broken down into glucose and broken down into glucose and galactose. The pathology of this disease is characterized by the absence of the enzyme aldolase B. And this would be indicative of hereditary fructose intolerance. Okay, yes, I'm picking up where I left off. The pathology of disease is characterized by the absence of the enzyme aldolase B, an essential enzyme that breaks down fructose phosphate into glyceraldehyde and dihydroxyacetone phosphate. This process causes a buildup of fructose 1-phosphate by the liver, with subsequent liver damage and toxicity of the liver. Galactosemia would not be likely, as the infant's glucose levels would rise following administration of epinephrine. A glucose 6 dehydrogenase deficiency would also result in hemolytic anemia, and jaundice in most infants would be mentioned in the symptoms as well. This disease is characterized by a deficiency in this enzyme, and results in the reduced form of glutathione. Catalase and GSH are needed for the removal of hydrogen peroxide from red blood cells, and if this is absent, it results in the destruction of the cell itself and would result in subsequent hemolytic anemia. My references are also listed at the bottom following this case study as well. All right, thank you so much.